Thank you very much for this invitation. I will share with you our experiences that happen in the third year of the undergraduate training of our medical students. We have a 6-year medical student program, and I will report on this experience, which is based on the principles of community-oriented primary care. Community-oriented primary care has been developed in the previous century, already in the 40s, by Sidney and Emily Clark, when they looked at their community in South Africa and saw that it's not enough to react to the daily problems of the people, but that they needed to look at the upstream causes of ill health and to blend information from their individual patient encounters with epidemiological data in order to make a community diagnosis. We have transformed this in an educational activity where we involve medical students, social pedagogic students, sociology students, and health promotion and management students, because we think that an interprofessional approach will be an added value in this confrontation with the needs of a community. So let's go to this year, the 24th of March, and see what happened in different parts of the city of Ghent. Where are all the students now? Well, they are in the community health center and no more in the classes at the university campus. The community health centers are linked to university. We use them as training places, and these are integrated centers at the primary care level of family physicians, nurses, dietitians, health promoters. They take care of groups of patients that are on the list. In this community, for instance, it's a very multicultural community with 65 nationalities, and it gives an integrated primary care with an integrated payment system using a community-oriented primary care strategy. On Monday morning, it starts with an explanation about the history of this community. It's important to understand how a community has been transformed from a rural community in the 18th century to an industrial one in the 19th century, and then became nowadays a very multicultural community. A healthcare provider has to understand what the origins of the actual situation of a community are. We try then to prepare the students to do a visit towards a family living in poverty and facing health problems. They prepare the interview with that family, looking at the background data, the illnesses of the people in that family, and prepare also how they are going to do this interview, which are the points they are going to address in order to understand the context of the illness. For most of the students, this is a very important and also very often very impressive experience, because they have not yet been in contact with people living in difficult situations. Sometimes they are very much shocked about it. They did not know which kind of living conditions people are living with. And then they are going to visit 3 healthcare providers that take care of that family in order to interview them, nurses, family physicians, social workers, other care providers, and to understand the perspective of the care provider towards that same family. So they understand them both sides, the family side, the patient side, and the provider side. And then they bring this information together on Tuesday afternoon, and they report on their experiences. They give a report about what they understood as the needs of the family, and they also add information that they have encountered when they were walking in the community, walking in the neighborhood, and what was the important facts that they have seen there. They then combine that information with epidemiological data, with all kinds of figures on morbidity, but also with the criminality statistics of that neighborhood in order to understand the context. And they try then to find all the information that is needed to identify the community's health problems in order then to prepare afterwards an intervention, as it is described in the COPC process. So here you see the picture of the community diagnosis. They put the positive points looking at the capabilities of the community and also the negative points. And then they see what is the main problem. And very quickly they shift from a medical and a disease-oriented context towards the upstream causes of ill health, poverty, facing problems with housing conditions and this. And then they discuss, and very often this is an interprofessional clash of cultures, because the medical students immediately come up with solutions for the problem, whereas sociology students and social pedagogic students try to understand whose problem is it? What is the background and the context of this problem? And it's very good to confront these different cultures of different groups of students in order to enhance the process of reflection. Finally, they make a brainstorming because at the end of the week, they have to make a presentation towards stakeholders of the local community about the intervention that they propose in order to improve the situation of that community. And so on Friday afternoon, they meet with people from the local community and with their fellow students, and they explain to them what happened, what are the proposals that they make to improve the situation. Also, they make a poster that can be used by the community. Here, for instance, was a group that focused on the need to understand the language and to learn the language, the local language, which is Dutch, and how this could be tackled in order to improve communication within the community. This group was about how we can understand each other, how we can be a very much stronger community, working all together. And finally, this was about the need for a restaurant in the community to have a place to meet and also to be confronted with healthy food. Finally, they write an advocacy letter to a provider or an agency related to the problems of the family that they have visited. And sometimes the agencies react very positively in improving the situation and the care for the family. So the students then experience how important it is to be advocates. And then we assessed, of course, what was the opinion of the students after this experience. And for instance, as a care provider, it's your duty to continuously improve the care system. Well, the students agree with that. So they understood the message of the Lancet Commission. And they also agreed very much that in order to eradicate social inequities in health, that we should tackle the upstream causes that are at the level of education, income, and work. They did not agree with the statement that says people living in poverty are to a large extent themselves responsible for their situation. So they did not want to fall into the trap of blaming the victim. They were absolutely not in agreement with the statement, it's better for a family physician to only focus on curing diseases. So they understood the broader task of primary care workers. To work with students from other disciplines was for them an enriching experience. So the interprofessional dimension is very important. And they did not become negatively depressed about their confrontation with this poverty, because in majority did not agree with the statement that they didn't see solutions to all the problems of that community. And finally, they agreed with the statement, healthcare is politics, understanding the wider aspects of their job. Organization is a very cumbersome thing. Logistics are important, 280 students, 64 community residents, so that's an important challenge. But we hope that through this experience, that students in the future will be prepared to take that empty seat and that they will be members of the community platform in the communities they are going to work with. I thank you.
Thank you. Our next speaker is Linda Kosser of the Association of Schools and Colleges of Optometry.